Hi, I'm Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota. Today, we have a presentation on prevention in older adults, and this is a project through the Dakota Geriatrics Program, which is a federally funded HRSA program called the Geriatric Workforce Enhancement Program. So the objectives for today are to firstly align preventive services with older adults' remaining life expectancy, as well as considering their cognitive status. We also want to talk about how to apply the annual wellness exam enhanced with geriatric assessment. Topics covered include cancer screening, other preventive measures, lifestyle counseling, geriatric syndromes, immunizations, recommendations for chemoprophylaxis, and then finally the annual wellness exam. I just want to mention that I'm including various artists in this talk and may make comments periodically in relationship to each slide. This particular painting is a self-portrait by Grandma Moses, who was a Vermont painter who started painting when she was 76 years of age and lived to be 101. So prevention needs to be guided by remaining life expectancy of the older adult. Generally, we use most of the screening measures for individuals who have greater than 10 years of remaining life expectancy, although we need to consider highly functional individuals who may have less remaining life expectancy. And then we need to consider excluding preventive measures for those individuals that have moderate to severe dementia. Furthermore, functional status is always important in considering preventive measures, particularly if there's advanced functional impairment. And of course, if somebody has 6 months to 1 year of remaining life expectancy, appropriate for hospice or palliative care, those individuals too would be excluded from preventive measures. So it's important to have our prevention efforts align with what matters to the older adult. And we want to consider not only the length of lifespan, so the quantity, but we also want to consider the quality of life. And the whole goal is to really maintain functional independence. In terms of cancer screening, the goal is to identify cancer in order to prevent morbidity and mortality. We need to balance that with the cancer screening harms, which include anxiety, complications, false reassurances from false negatives, and then also overdiagnosis, where discovery of a tumor may not really impact the lifespan, and this is certainly seen in prostate cancer with older men. Well, why even do cancer screening in older adults? And the answer simply is for colon cancer screening, the incidence increases with increasing age. And so you can see the information here from most recently from 2020, where the rate per 100,000 population basically goes up exponentially, as you can see at the end of the bar graph here for 85 and older that have the highest incidence of colon cancer. But the good news is that colonoscopy, which is recommended every 10 years without any associated complications, results in a lower incidence rate of colon cancer. And you can see how things have progressed over the last couple of decades, where the incidence rate of cancer has gone down considerably, by the increased use of colonoscopy. So what are the screening tests for colorectal cancer? You can see the recommendations here for 50 to 75-year-olds. Certainly the fecal occult blood test every 5 years would be one recommendation. Colonoscopy or CAT scan colonography or flexible sigmoidoscopy would be all reasonable interventions or assessments, whereas in the 76 to 85-year-old group, really the idea of testing through any of those measures mentioned above for the 50 to 75-year-old need to be taken in accordance with what the patient's overall function and health status may be. In individuals over the age of 85 years old, no colon cancer screening is recommended simply because of the remaining life expectancy would not be there to justify further cancer screening. What about breast cancer screening? So it's important to discuss mammography at least every 2 years if there is greater than 10 years life expectancy in older women. So just remember the average life expectancy for women is 81 years of age. There's no evidence that mammography improves survival in individuals over the age of 75. And when we look at the impact of clinical and self-breast examination, there's not a lot of good data to support either. However, it is generally recommended that a clinical breast exam be done as part of a annual physical exam. In terms of cervical cancer screening, the recommendations are to have pap smears every 3 years, or if you combine it with HPV testing, that would be done every 5 years. And basically, you can stop at, after the age of 65 for women that have had 3 consecutive negative cytologies by pap smear or 2 negative papillomavirus screenings prior to the age of 65. And this discontinuation of pap smears can be done regardless of the sexual history or new sexual partners that might be associated late in life. In terms of prostate cancer screening, it's not recommended to do screening for men over the age of 70. It would be good to discuss the prostatic serum antigen with what we call the young old, those that are between the ages of 65 and 70. And it's important to point out that 80% of positive PSAs may come back as false positives when you have a fairly low threshold of 2.5 to 4 micrograms per liter. In terms of lung cancer screening, it's now recommended that low-dose computed tomography be done in 55 to 80-year-olds who have had a 30-pack-year smoke history and currently smoke or have quit within the past 15 years. So the level of evidence for that is quite good. It's level A. In terms of stop screening, these would be individuals who have not smoked for 15 years. And the other aspect is that if the surgical intervention wouldn't really improve life expectancy, or I might also add if they have low functional status, those would all be indications for not screening any further. And of course, if the patient says, I just don't want any further additional screening because I wouldn't have surgery anyways. All right, so the United States Preventive Task Force indicates that there's insufficient evidence to recommend things such as a whole body skin exam. If a dermatologist does it, maybe a little bit better. Screening for cancer of the oral cavity, urinary tract bladder, or thyroid is not indicated as a routine measure. The tough one in terms of ovarian cancer, there's no recommendation for screening for cancer antigens, ultrasound, or pelvic examination. Although I will point out that older adult women that may complain of bloating or fullness, that could be one of the signs of ovarian cancer. So based upon symptomatology, it may be important to follow up with some of these tests. However, just as a routine screen, it's not recommended. And again, no screening pelvic examinations in asymptomatic women. In terms of, again, asymptomatic older adults, bacteriuria should not be tested with urine analyses. a asymptomatic individual should not get carotid duplex ultrasonography. There's no point for screening hyperlipidemia with LDL if they're completely healthy. And then also, there's not necessary to do treadmill exercise testing if there's no history or symptoms of coronary artery disease. So the other aspect of screening against asymptomatic older adult, different thoughts here is that glaucoma should not be routinely screened, although I'll point out that glaucoma screening is part of the Welcome to Medicare exam, and Medicare does pay for it. But there's no evidence that spirometry tracking of COPD makes any difference in health outcomes. Again, healthy individuals who do not complain of symptoms of obstructive sleep apnea don't warrant a sleep study. Routine screening for osteoporosis is not really recommended unless there's risk factors. In terms of peripheral vascular disease, routine use of ankle brachial index is not recommended. Generally, if you can't feel a pulse, then that would be an indication that there is a sign of arterial insufficiency, and that certainly would warrant a ABI request. And then in terms of thyroid cancer, there's no evidence that palpation really improves the detection of thyroid cancer, which is disappointing in individuals like myself who teach physical diagnosis to medical students. And we always talk about the importance of the neck exam as one of those elements that they need to learn. In terms of hypertension screening, it's recommended that it be done. However, if the blood pressure is elevated, that it needs to be confirmed in the home setting. And so it's important to have a home blood pressure cuff measured or calibrated with the clinical, so that the individual will know that usually they're automated blood pressure cuffs, and so you want to have a correlation to make sure that what they're testing. But generally, most studies show that home-based blood pressure measurements are about 10 millimeters of systolic mercury lower than what you find in the clinic. And whether you want to call that white coat hypertension or otherwise, the studies are pretty confirmatory that there is a major difference between clinical measurement of blood pressure and home-based measurement of blood pressure. Well, in terms of diabetes, I have a painting here by Diego Rivera of the larger BMI individual, and typical in older adult healthcare that's predisposed to type 2 diabetes or prediabetes. And so the American Diabetes Association recommends screening all adults over the age of 45 with either a fasting blood sugar, hemoglobin A1C, or a glucose tolerance test. And the United States Preventive Task Force recommends screening older adults between the ages of 40 and 70 who are overweight or obese. So just a little bit more refinement in one case. And I bring both of these groups' recommendations just to show that there are some small variations with actually each different kind of screening recommendation. So we always have to keep those in mind. In terms of aortic aneurysm screening, basically one-time screening for men over the age of 65 who've ever smoked, whereas there's equivocal evidence, if you will, for selective screening of aortic aneurysms in men who have never smoked. For women, it's not so much recommended. In terms of osteoporosis screening, so all 65-year-old women and all younger old women who are at high risk should be screened. And a DEXA scan should be considered for men, particularly those over the age of 80. I just want to do a side commentary here that Diego Rivera was the significant other of Freda Kahlo, who's we saw earlier here with, and Freda Kahlo always had a lot of her paintings with hearts and arterial systems connecting the lighter side here on the left and the darker side of her personality on the right.